So now our next in line is anatomy, which is very important. Anatomical precision and biomechanical restoration determine functional success. I am Dr. Juhi Agarwal. I am professor at GMC Bhopal. So I will, without any delay, I will start because it's a live workshop and we need to be on time. So next slide, please. Next. मैं ही कर लूँ. कहाँ से move होएगा? So today we'll be covering elements of female pelvis. We all are aware of biomechanics of supports of pelvic organ, principles of surgeries in urogynecology, and spaces of female pelvis with surgical relevance. Next. So I just want, I will explain you with a very simple example because I as a teacher, I think that it should be very simple. So we should think of a packet. Now the cover of the packet is the pelvic bone. The fruits are the muscular support or the dynamic support, and the ghasfus which we see straw, that is the endopelvic fascia. Okay, so this is how you should imagine pelvic anatomy. Now what these structure together do, they maintain anti-flexion and anti-version of the uterus, our pelvic organs. And moreover, whenever a quadruped animal becomes a biped animal, the female pelvis is tilted like this. Whenever we used to read anatomy, it was like this. So the horizontal, the vagina is almost horizontal. And the uterus is anti-flexed at an angle. So what happens is whenever there is increase in intra-abdominal pressure, this uterus comes down and closes this vaginal orifice, which is a hollow organ. So that is called as ball valve mechanism. And also the vagina is almost horizontal. So whenever the force falls on the anterior surface of the vagina, the posterior surface opposes it, and there is a slit valve mechanism and it closes. So altogether, pelvic organ does not get prolapse. Now here you can see these are interdependent system. If one system fails, crashes, there is force on other system. Okay. Coming to the bony pelvis. Are you leaving, Dr. Manisha? Okay. Thank you so much. Thank you. So first of all, we will be covering bony pelvis. First, we know that bony pelvis consists of three bones, ilium, ischium and pubis. This is ilium, ischium and pubis. So I will not go in detail. Here are the ligaments which are being attached. Now first talking about the muscular support, that is the levator ani muscle. Now levator ani muscle has two components, pelvic diaphragm, that is levator ani per se, also called as levator sling. It consists of pubococcygeus. Now it is pubococcygeus. I will come to the photograph. It is almost a straight muscle which has three components, that is puborectalis, pubovaginalis and pubococcygeus proper. What these muscles do actually is, they are bilaterally symmetrical and they insert in the central median raphe. So that median raphe, what it does, it encircle the organ and it insert on the opposite side. So that way they support, मतलब it's like झूला or hammock. मतलब अगर हम कोई झूला बनाना चाहते हैं तो what we do, we put a sling, we encircle it and then we will hang it on the other end. So it's like that. Second part is iliococcygeus. We will talk in detail about iliococcygeus. There is one more muscle which is not a part of pelvic diaphragm, but again it forms pelvic support, is ischio-coccygeus. Now here is a diagram or a photograph beautifully showing all these muscles. Now you can see that that here it is iliococcygeus muscle which is arising from arcus tendinous fascia, which Dr. Manisha was talking of. Now the name is suggesting it is iliococcygeus. So one thing which comes to our mind is it should arise from ilium. मतलब अगर हम pelvic bone देखें तो हमें लगेगा it should arise from ilium here and it should insert in coccyx, but it is not like that. It actually arises from the arcus tendinous fascia. Now this arcus tendinous fascia is the condensed inferior fascia of obturator internus muscle, which is on the ilium. Okay, so the condensed inferior fascia, which is arcus tendinous, is the fascia which is very important for us, and it is responsible to correct the paravaginal defects, as Dr. Manisha has talked about. Now, how to feel that where, मतलब this is all theory. हम practically हमें कैसे पता चलेगा कि whether it is arcus tendinous or whether it is sacrospinous, will come to it. So what you will do, we know that arcus tendinous starts from ischial spine, which is the nodal point, and it comes anteriorly. It is at the inferior margin of the obturator fossa, from ischial spine to inferior margin of obturator fossa and pubic ramus. So this is the attachment of arcus tendinous. So you can very well imagine, यहाँ पे uterus है, यहाँ पे urethra bladder है, और यहाँ arcus tendinous. So it is here. When you remove the dynamic support, that is the muscular support, here comes the facial and ligamentous support. You can see what all ligaments are here. Uterosacrals, here is the horizontal part of the pubocervical ligament. Vertical portion of the vagina is supported here. Vagina is just lying on this fascia. Then urethra, and of course the tendinous arch here. Everything is getting attached to the tendinous arch. That is the white line. So the beauty is these muscles are in conical shape. ये सब cone form करती है. So whenever you see that arcus tendinous, the brim of the pelvis, the arcus tendinous is actually the middle point of this cone. But if you divide this cone, here is the arcus tendinous. It is 5 cm below and 5 cm above. So that is how this whole true pelvis is being divided into two. So what are the surgical principles? Before we manage any pelvic organ prolapse or pelvic structures, we should know the surgical principles of pelvic surgeries. Restitution of support of uterus is important. Consideration during hysterectomy is very important. Corrective surgeries are fusion of anatomy, physiology and biomechanics. It's not just restoring anatomy. Reparative options are no longer limited to midline plications. When we were students, we were taught, plicate kar do. Cystocele mein plicate kar do. Rectocele में plicate कर दो. So nowadays, reparative options are no longer limited to plications. No treatment is available for myopathies and neuropathies. Mind it, Manisha has also stressed, whenever a patient undergoes labor, the pudendal nerve in the canal gets stretched. And also there is some damage to the levatorinae. Now these damages have been proven through MRI that these damages are permanent damages. So the option left with us is only to the option here is only to correct the endopelvic fascias. Okay, अब हमारे पास कुछ नहीं है, endopelvic fascia से ही हम उनको treat कर सकते हैं. Now coming to spaces which are important to urogynecology. Now one space which is important is the retropubic space which Manisha has talked of. मेरा phone. Now this retropubic space is a space just behind the pubis. That means जैसे ही आपने bladder का urachus को cut किया and you moved it posteriorly, the space which is formed is the retropubic space. Okay, and it is a very limited space. Laterally it is bounded by the external iliac vessels. इतना lateral नहीं जाना, मतलब 4 सेंटीमीटर मिड से इधर और 4 सेंटीमीटर इधर. Not beyond that. Okay, that is very important space. Again, Manisha ने जैसा आपको बताया था कि you can approach arcus tendinous through that fascia. So whenever there are anterior defects or defects in there is hypermobile urethra. This is the space which can be exploited. And this space is exploited in TVTs and birth suspensions. Okay, TVT में भी हम ऐसे ही करते हैं. हम अभी बताएंगे विनीत मिश्रा सर कि how do we do TVT. TVT में भी यहीं से आप needle डाल के और यहाँ से निकालते हैं and the tape hangs here. Okay. So this is very important space, that is space of, also called as space of Rinses. Now the second space which is very important is the obturator space. Now since we are getting, it is delaying, so I am just covering it. Now what is obturator space? Obturator space, if you imagine, there are two muscles. One is obturator internus and one is obturator externus. See, like this. Now there is obturator membrane covering the obturator fossa. Okay, there are membranes which is covering the obturator. Pelvic floor concept, I have started with the spaces, so I will be covering pelvic floor later. First I will cover the spaces. The one is, I have already talked of arcus tendinous fascia pelvis. I will not go in detail. Here you can see very well that how this arcus tendinous fascia is arising from ischial spine to the pubic symphysis, covering the inferior margin of the obturator fossa. Okay. So surgical significance is paravaginal defect. Here you can see laparoscopically how you can see the white line. It is very well visible. The moment you remove the bladder, laterally you can see the white line, that is arcus tendinous fascia. Now space of Ritzius I have already talked of. You can just see the picture. You can see in sagittal section, this is the space of Ritzius with fat, full of fat, and this is a very good diagram which is showing space of Ritzius. You just remove the bladder and you can see space of Ritzius behind pubic symphysis. Now this is the transobturator space I was talking of. Now this transobturator space you can see. I was talking of that there are two muscles, externus and internus, and there is an obturator membrane. Okay. So why this space is important for us? Because whenever we do transobturator tapes, what we do is we pass our needle through the groin of the women, and groin means insertion of adductor longus muscle. Now adductor longus muscle gets inserted just beside the clitoris. The first muscle belly which we feel at the level of clitoris in lithotomy position is adductor longus ligament. We just pierce our needle, and the shape of the needle is so that it gets curved initially and it should perforate the obturator membrane. It should perforate the obturator membrane and come out through the vagina. Okay. So why it is important? What is the significance of knowing this space? Obturator membrane is a sandwich structure between internus and externus. One thing. Superior margin of the obturator fossa and the superior margin has obturator canal. Now this obturator canal has vessels and nerves. If you fiddle with the needle, then you may injure these vessels. So that is the significance of transobturator space. See, here you can see there is obturator canal, and it is just diagonally at 3.5 centimeter from the obturator membrane. So whenever you insert the needle, you should not fiddle. Once you are inside, you just have to rotate it and bring down. Next significant space is the sacrospinous space. Now sacrospinous space, we know that sacrospinous is a ligament. Basically it is condensation of the superior part of the coccygeus muscle, which is the second muscle which was important, which was supporting the pelvic organ. Now this sacrospinous ligament is very important. Vaginally, when we want to suspend our vaginas and warts, it is a very good method. But why again it is important? What are the tips and tricks which we should follow while we do sacrospinous suspensions? Now again there is one nerve which goes superior to this sacrospinous ligament. That nerve is our sciatic nerve. So if we feel that we will palpate the spine, and if we would like to pierce our needle just beside the spine, that means it is there we can injure the sciatic nerve. So always remain medial. So and never try to pierce or go above the sacrospinous ligament. Always pierce the substance of the sacrospinous ligament so that you can take a bite, strong bite, and so here you should be very careful about the structures like nerve and vessels and rectum. Now uterosacral space, we all know its significance is in cultoplasties. Here are two other spaces, vesicovaginal and rectovaginal space. Now this is presacral space, which is important. Actually this presacral space can be approached through abdominal route, either laparoscopically or by laparoscopy. Here you have to use a foreign material or mesh to suspend pelvic organs. This is the pectineal space. Now pectineal space is defined as a space, it includes space of Ritzius as well. A space which is formed by the Cooper ligament. Now we know that Cooper ligament पूरा इसमें यहाँ से यहाँ तक होता है. कहाँ से? Anterior superior leg spine to pubic symphysis. Now all this space is pectineal space, but the space which is relevant to us is just besides the external iliac. You don't have to go beyond external iliac because that is the catch point. you don't want to injure. So whenever we do pectopexy, abdominal route, pectopexys we will be watching, we will suspend it to the pectineal ligament, and that is by abdominal route. जो birch किया था हमने, उसमें भी हमने pectineal ligament में ही किया था, but that was for anterior defect, urethral defect, और वो हमने उसको medially ligate किया था. यहाँ पे we will go more lateral. Okay, that is for pectopexy, and here birch was medially, and it was urethropexy. Okay. Now coming back to the concept of perineum in short, which I have missed. Now the concept of perineum, actually क्या हम लोग बहुत confuse होते हैं हमेशा. मतलब since our UG days, what is pelvic floor, what is pelvic diaphragm, everything gets mingled up. So always remember there is pelvic floor. Pelvic floor, suppose the pelvic floor is like a multi-story building and it's a ground floor with a basement. So the ground floor is the pelvic muscles, that is the pelvic diaphragm, and the basement is basically the perineum. So the levator ani forms the roof of the basement, and there are then two floors in the basement, that is deep perineal pouch and superficial perineal pouch. Now if you imagine a perineum of a female, when the female is in lithotomy position, the moment you remove skin and superficial fascia, you will get superficial perineal pouch. आपने जैसे ही उसकी स्किन हटाई, you will see superficial perineal pouch. Superficial perineal pouch के content, what are the components of superficial perineal pouch? All these muscles, bulbocavernous, ischio-cavernous, and superficial transverse perineal. Now these muscles are the muscles when we do episiotomy, and these muscles are responsible for antroital tone, and they get attached at a central tendon that is called as perineal body. Not only these, but the muscles of deep perineal pouch and also the muscles levator ani, they all get attached at the level of perineal body. And it is also responsible for lower 1/3 of support of vagina. Okay. So these are the components of superficial perineal pouch. Yes. And if we talk of deep perineal pouch contains all these muscles, sphincter urethrae and transverse perineal, deep transverse perineal muscles. This was what Manisha was talking of. The detrusor continence and the urethral continence differs. We know that they differ, but still there is some attachment of all those muscles. You can see vertically. These muscles are all attached. So wherever anything goes wrong, the support of urethra gets lost. So these are the contents. This is perineum, that is the urogenital triangle and the anorectal triangle. And these triangles are not the triangle as they are looking in the figure. Actually they are diamond shaped and angulated. And they are attached at perineal body. The base, common base is the perineal body. So that is all. I will come to conclusion then. So to understand urogynecology, to understand the procedures, you need to understand all the anatomy. So the urogynecological surgery is applied pelvic anatomy, not just a technique. Success depends on accurate understanding of D. Lancey's level 1 to level 3 supports. These are the vaginal support. Safe surgery requires mastery of pelvic spaces, facial planes, and neurovascular pathways. Procedure selection must be defect specific and anatomy driven. Most complications arise from anatomical misjudgment. That is why we have talked of the intricacies about anatomy. And the take home message is understand the pelvis precisely, operate confidently and safely. Thank you.